Good evening, everybody in the Americas. A late good evening to those of you in Europe, and a early morning for those of you in Asia. It's our third update of day 3 of our Odyssey COVID-19 Study-A-Thon. It's exciting to see how much activity has happened even here on a weekend around the world. Truly inspiring to see how much collaboration has been taking place and how much hard work is going in to collaborating together. You guys heard from Danny early this morning, my time, and again in the middle of the day about all the progress that many of the work groups have made. And we're really excited to be able to share with you some of the progress and some of the tangible outputs that have now been produced now just 3 days into our Study-A-Thon. So let's just get right into it. So first, I think it's important for us to continue to situate ourselves in why we're doing what we're doing. And unfortunately, COVID-19 continues to grow and escalate around the world. By the latest count, there are now 659,000 patients who've been inflicted with this disease, over 30,000 deaths. I heard today, actually, a member of the Odyssey community reached out to say that they fell ill from this disease. So our hearts go out to them. Our hearts go out to all of the first responders that are caring for patients and to everybody who's challenged by this circumstance. I think that it's, we're clearly seeing around the world the importance that's being placed on developing public health solutions that can make a meaningful difference. And it's in part why I'm so excited by the work that we're doing, because now we are much closer to actually providing very real answers to very important questions that can directly support this current crisis that we're in. So what Danny and I are going to do this evening is provide you a tour of some tangible output that you haven't seen yet, that we have made as a community, and to show you the next steps that we'll be able to go based on here. The first journey I'm going to take you to is atlas.odyssey.org. Now, as you all recall, atlas.odyssey.org is our final stage ground for all of our finalized cohort definitions and analysis packages. This is the place where only after cohorts have been designed, characterized, evaluated, and reviewed by our clinical teams can we actually adjudicate them and actually move them forward to be posted on atlas.odyssey.org. And you probably recall last night I showed you how this was empty, because we learned a lot over the course of our phenotyping group about all of the challenges represented across our international data network, and that caused us to actually withdraw the definitions that we had speculatively considered. But I'm super proud of the group and to be able to share with you that as of our 7 p.m. Eastern Time update right now, we have 113 finalized cohort definitions that are available for use across the network. Now, you might be wondering, well, what are those cohort definitions? And what I'm really proud to share with you is that all cohort definitions necessary for our characterization studies have been completed and packaged up for a study for everybody to run. And all cohort definitions necessary for all 3 of our primary prediction questions have also been finalized, packaged, and are packaged up into an analysis design and ready to run. Just to give you a sense of the complications and the challenges that face this, let's take a look at what it takes to define COVID-19 in our data. Our first published, released cohort definition is COVID-19. What's going on here? Oops, I'm sorry. ID1 is patients hospitalized with COVID-19. This is our narrow definition. This definition is based on the requirement that data sources are actually capturing COVID-19 diagnosis codes or having positive tests. And in order to find hospitalizations with patients with COVID-19, What we need to develop as a model is to look for inpatient visits after December 2019. And for those visits, we are looking for diagnosis codes of COVID-19 that occur in the 21 days preceding or during hospitalization. We require a spectrum of both standard concepts and source codes, recognizing the challenge and the urgency that's going on with specifying data and transforming it in rapid time. There are some pre-coordinated measurements that basically say someone is COVID-19 positive, and that captured in the measurement table. There are also measurement values associated with those that have COVID-19 tests and whether the values are detected, positive, or present. Those values could either be in the measurement table or the observation table. And so for every one of those inpatient hospitalizations that represent a potential COVID-19 case, we've applied inclusion criteria to require those patients to be over 18, that those patients must have at least 1 year of prior observation, and that those patients must not have been hospitalized for COVID-19 in the prior 6 months. Now, this is one of the 12 cohort definitions that we had to create to collaborate in great leadership by Ed in the characterization group. But just to highlight that this definition is just defined, narrowly defined COVID-19. I want to illustrate for you what it takes to define broadly defined COVID-19. Because as you know, many patients are out there wondering about whether or not they have this disease based on a constellation of symptoms. So how do we model that in the OMOP Common Data Model? Well, to define a broad-based definition of COVID-19, our group has collaborated to look for hospitalizations that have all of those markers of COVID-19 diagnoses, pre-coordinated measurements, and measurement values and observations. But we're also looking for concepts associated with suspected coronavirus, of which there are some codes that have been added to the vocabulary. And then we're also using a very complex set of logic to look for whether patients have fever, and fever can be defined as a diagnosis of fever, a measurement of fever, a measurement value associated with body temperature being between 38 to 42 Celsius or 104 to 120 Fahrenheit. But for those patients that have fever, we also require that they also have one of many of the other symptoms being observed for COVID-19, namely cough, dyspnea, myalgia, malaise and fatigue, or pneumonia. So this is what it takes to be able to find patients in the real world who have COVID-19 or associated symptoms that may represent a suspicion of COVID-19. Now, we have defined a variety of cohort definitions to support the characterization, and I'm proud of the phenotype group for us taking each and every one of those specific components in those definitions and doing a thorough evaluation, investigating and evaluating those components across data in US, Europe, and Asia to make sure that we have confidence in each of those pieces and to bring them together into this large composite definition. Now that those definitions are done, I'm extraordinarily proud to announce that the characterization group has released a study package. It's currently available out on Ed's GitHub repo, but Odyssey COVID-19 Hospitalizations Characterization is a study package taking all of the 12 cohort definitions that have been created to characterize hospitalizations with COVID, as well as hospitalizations with flu from the 2009-2010 year when the avian flu pandemic struck us, as well as to use a benchmark of hospitalizations for flu from 2014 and 2019 as a contemporary benchmark. All of those cohorts have been created and packaged up into this characterization study that has been made available. And I believe that this study is now actually being executed across multiple sites of the network. And thanks to Kristen and the team that are coordinating the network executions to get this package out there running across our network. And hopefully tomorrow we're going to be able to see a sneak peek of some of the results that come from this characterization package. So congratulations to the characterization group for achieving a very critical milestone of releasing a study package and congratulations to the phenotype group for developing and evaluating those phenotypes so thoroughly. An amazing amount of work went into that, but I feel extraordinarily confident about the quality of those components. I also want to give a big shout out to our prediction group, who have defined 3 critically important prediction questions to help us flatten the curve. And those prediction questions have now been fully specified into patient-level prediction analysis specifications with completed cohort definitions that we're going to be able to use and package up to execute shortly. Just to summarize and to demonstrate how those ideas that we came up with at the start just 2.5 days ago, how they've been implemented, I'll walk through the prediction problems for you. Our first question is, amongst patients who present with flu symptoms, who are the patients that are going to require admission into the hospital? To define this prediction problem, we've created a cohort of patients who have a general practice or outpatient or ER visit who present with either COVID, influenza, or those flu-like symptoms of fever, cough, myalgia, dyspnea. But for these patients, we're looking for the first time that they present with those symptoms. So we're requiring that those patients have no prior symptoms or pneumonia in the last 60 days. So think of this as the real situation facing patients every day around the world. They wake up with a fever or cough or feeling a little bit tired or maybe having shortness of breath. The current US CDC guidelines suggest that when those symptoms present themselves, they're supposed to call a hotline to talk to a trained medical professional who's going to help them determine whether or not they should stay at home in self-isolation due to a suspicion that they may have this disease, or whether or not they should seek medical services on the basis of the severity of their symptoms. Well, this prediction problem aims to help that situation exactly. By identifying patients who have the symptoms, and this is the first time they're presenting with those symptoms, think of that as the first time that they're calling that hotline. What we're trying to do is predict amongst those patients at that moment that they're making that phone call, which patients are going to require going to the hospital. And to do that, we're predicting 4 different outcome cohorts that have now been fully specified. We're going to predict which of those patients require admission to the hospital due to pneumonia, which of those patients are going to require going to the hospital due to either pneumonia, acute respiratory distress syndrome, sepsis, or acute kidney injury. And we're also going to be able to predict which of those patients are going to have serious hospitalizations, meaning that they are hospitalized due to pneumonia, ARDS, sepsis, or kidney injury, but they require intensive services such as mechanical ventilation, intubation, tracheostomy, or ECMO therapy, or those patients succumb to the disease and die within 30 days. We are also predicting all-cause mortality within this time period. So think of this, we have a population at risk, those patients experiencing the symptoms, and for those patients, we're going to try to predict all of these different 4 outcomes within our data. To do that, we'll be applying multiple machine learning algorithms to this. The team's initially focused on using a large-scale lasso regression approach to this. And we'll be developing that model using a range of features, including past medical history of conditions and drugs that the patients have had in their medical history prior to presenting the symptoms. Think of this as if one said, I have the following symptoms, we want to answer the question, are there additional questions that we should ask the patients that could give us some insights into whether or not those patients are going to go to the hospital or have serious adverse outcomes? If we can develop a model, there's a clear critical clinical application need to use this model. And so I'm really excited to see the patient-level prediction team packaging this up, training models across our international network, and then hopefully, if we see intriguing results, to be able to try to do some external validation and ultimately share this model with the entire health community to think about how it could be used to support current clinical practice. Now, that's just one of the prediction problems that the patient-level prediction team is focused on. The second one that I'll highlight is amongst those patients with a GP visit presenting with flu symptoms by going to the doctor, At a GP, we can generally readily determine whether a person has or does not have pneumonia at that outpatient visit. And the question we want to ask is, for those patients who are sent home, basically told to go home and recover on their own, which of those patients sent home ultimately will have progression of their disease that will require hospitalization? Here, the patient-level prediction team is focused on developing two models because we recognize two critically important clinical states that we want to examine. There will be those patients who have flu or flu-like symptoms, but on presentation to the GP, the GP does not actually identify pneumonia. They don't hear it or see it on an X-ray. So for those patients, most of them are going to be sent home. But the question becomes, if they don't yet have pneumonia, what's the chance that they're going to develop in a couple days and get worse and require hospitalization? And it's critically important for those patients who are worried about their health that if they're told and told to be sent home, even though they don't have pneumonia, it'd be reassuring if we could tell those patients that they have a low risk, or if we can identify which of those patients may still be at high risk given their baseline characteristics. But it's also recognized that in many circumstances, patients who present may in fact at a GP may in fact already have pneumonia. And oftentimes, if a clinician observes pneumonia in an outpatient setting, they'll probably be sending them to the hospital for clinical care. Certainly in a case where we don't have healthcare resource constraints, this would likely be something to do to make sure that we manage the pneumonia appropriately. However, in these trying times where hospitals are increasingly being filled and we have to make difficult decisions about how to allocate resources, we thought it would be useful to ask the question, if a patient is observed to have flu-like symptoms and is diagnosed with pneumonia, can we predict which of those patients are going to require hospitalization after we send them home? And the argument there is that potentially there are some patients with pneumonia who are at lower risk, and so we could feel comfortable sending them home and knowing that they're not going to have some sort of recurrence. But there may be other patients with pneumonia for which sending them home might not be the right decision. And so we hope that this model, if proving to be predictive, could actually be a valuable decision support tool, not only for reassuring patients about their risk, but also for helping GPs who are out there on the front line trying to make these triage decisions. And the patient-level prediction group did a great job of reviewing the literature and recognized that there doesn't seem to be a model that's really fitting this particular niche that we're going after. So we're excited to see whether or not this model, whether we can produce something that would be usable and reliable for patients. The last prediction problem that I'm excited to see the work be done is for patients who are hospitalized with pneumonia. Which of those patients are going to require intensive care services or intensive services or succumb to the disease? And in this particular context, our target population are those who are admitted to the hospital with pneumonia. And our prediction question is, can we use the information before they walk in the door to the hospital to determine which of those patients during that hospital stay are going to either have require intensive services, meaning ventilation, intubation, tracheostomy, or ECMO therapy, or which of those patients are going to die. The argument here is that, again, hospitals are making difficult choices about how to prioritize intensive services and for which patients. And so if we're able to train a model that can discriminate those that ultimately will require intensive services at some time during their admission, that could potentially be a useful prioritization scheme to help hospitals and healthcare providers determine which patients need to get into the hospital soon and which patients need to be escalated up the priorities for these intensive services to hopefully help with recovery. I know there's been a lot of important, challenging discussions that the patient-level prediction group has been having, particularly related to the medical ethics associated with rationing and allocation of healthcare. And it really hurts my heart to think about the difficult decisions that healthcare providers are having to make around the world. But if we can do something to provide objective, rational information to help those tremendously difficult decisions, then I think we've made a very, very significant contribution to the entire plight that we're under right now. So I've just shown you that we have a characterization study package that has been released. Congratulations to the team. I've just shown you that all of the prediction studies have now been fully specified. Cohorts have been designed, evaluated, and made available. And the draft patient level prediction studies have been posted in our atlas-covid19.odyssey.org environment. And these will now be packaged up by the patient level prediction team. Special thanks to Jenna and Peter, Ross, Cynthia, for all of their hard work in shepherding this to this point. What I'd like to do now is actually turn it over to Danny, who probably has some of the most exciting results to show, not just how do we package up things, but what happens when we run a package. And to do that, we're going to walk you through the diagnostics results that have just reported out on some of our estimation studies. Danny?
Thank you, Patrick. Yes, I'm going to start by reminding you that we are studying 3 or 4 groups of drugs. But I'm going to be focusing on hydroxychloroquine, which is a therapy that has been adopted as kind of current practice for treatment of COVID disease with very little evidence. And actually, there was a paper out today titled Clinical and Microbiological Effect of a Combination of Hydroxychloroquine and azithromycin in 80 COVID-19 patients with at least 6 days of follow-up and observational study. You can quickly have a look at the power that we will have in our study here, comparing hydroxychloroquine to sulfasalazine, which is a comparator treatment that we use also for the same condition. And you will see very quickly that we're going to be multiplying that 80 number by a few hundreds. I think it's also important to bear in mind that we are not only doing quick research and research that will have an impact, but also research that has quality. And we have taken it very seriously, and with the estimation group, we have taken all the steps to make sure that we pass all the diagnostics before we reveal any findings. And in fact, if you go, for instance, to the propensity score distributions, you can see how these distributions are very much alike, and there's a lot of overlap between those 2 groups, which is already a good tip. And if you want to look at the imbalance in observed confounders, you can see how before propensity score stratification, there's quite a lot of imbalance. So there's a lot of variables that are different, but after propensity score stratification, there's no real imbalance in there, which made me very happy. This is in terms of observed confounders. And although the list of confounders in there is massive, of course, we also wanted to look at unobserved confounders, and we have the systematic error plot that will help us understand where there is any residual confounding ongoing. And we were very happy to notice that also that plot is reassuring in that we don't have too much unresolved confounding going on, and that we can handle that situation. Based on these findings, we have now unblinded the results, the analysis in one of the databases. That's the one that we've been able to analyze so far, and we've now launched this analysis in the rest of the network. And I think we're going to have very interesting findings by tomorrow sometime.
Danny, probably for those of you on the line who are not familiar with this plot, just to orient you to this, what you're looking at here is a plot where every dot is a negative control outcome, meaning an outcome that is known not to be associated with hydroxychloroquine or sulfasalazine. So we would expect that any method applied to that should produce a relative risk near 1. The plot's showing you the hazard ratio on the x-axis and the standard error on the y-axis. This dashed red line that you see, this represents our traditional paradigm of p less than 0.05. So dots below the dashed line would be considered statistically significant. Dots above the line would be not significant. So we have run 62 full-fledged studies on 62 outcomes that we believe the true effect is 1. By random chance alone, you would expect 5% of those estimates to be statistically significant. And what you can see is when we ran this study, exactly 5% of the negative controls were statistically significant. That does not mean we discovered anything. That means that we're actually now fully calibrated to understand the error. The question, and what we'll dive into tomorrow as we go through the results, is now that we have confidence that this method for this comparison in this database is not generating biased results, it gives us tremendous confidence to interpret the effect estimates that we are going to be producing for all of the outcomes of interest. And so certainly stay tuned to hear from Danny and the team about what we find as we start releasing results from additional databases and additional outcomes.
Yeah, Patrick, let me read from the abstract of that paper that was published today. The authors say, we believe other teams should urgently evaluate this cost-effective therapeutic strategy to both avoid the spread of the disease and treat patients as soon as possible. So I think that is exactly what we're doing here.
Right.
I'd be happy to take questions if there are any questions.
Yeah, so I'll throw questions at you, Mark. So Mark's got a question here for you, Danny. So the systematic error for this hydroxychloroquine, it seems to show 95% coverage with and without calibration. Does that mean we've got a nice study design?
That's nice for you to say. I think we do have a very nice study design with a comparator that's used for a very similar indication to the target therapy. So I think that's probably why this is working so well.
So there's a shout out and congratulations to Ed. And so certainly I want to echo that. The characterization group and the prediction group really collaborated amazing. And I think that's coming from Kristen, who's actually now taking the lion's share of the work to make sure that we get this package in the hands of everybody who's going to run it. So Kristen, thank you. And thank you for pushing through and getting this out to all of the sites. I know we're really excited to see results from our colleagues in Korea as they're waking up here now. And hopefully we can also get this run against our sites in the US who have some initial COVID cases, and we should be able to summarize them using this package. For all of our 36 data partners that are already signed on, though, I want to highlight that this study can be run by you because it not only is summarizing COVID cases, but it is also producing the necessary benchmark information for the flu when we had the avian flu pandemic back in 2009-10, as well as having a benchmark comparison of what does the flu look like in 2014 to 2019. So this is a package that any of our data partners can and should run, and we're really excited to see results from everybody. But of course, I think the world's going to be watching to see our results of our data sources that have initial populations with COVID-19. There's a question here about the analysis you're showing here, Danny, about what's database we're showing. So just to zoom in a little bit so that people can see it a little bit better. What we're showing on the panel here is results from the Optum DoD database. So this is a US claims database of private payer claims data. Danny, I'm going to throw a question at you. How does the SCCS portion of the hydroxychloroquine study work? Can you describe that study a little bit?
Absolutely. So the SCCS, I haven't shown that because we don't have it in the Shiny app, but Martijn, I'm thankful to Martijn, who has been able to run the negative control outcomes of that analysis. So the self-control case series analysis has basically the advantage that because it is fixed in the same patients being their own controls, there is no fixed confounding in there. But of course, there's the limitation that potentially there could be time varying confounding. And we've been looking at a self-control case series adjusted for season and age, and that seems to work really nicely against negative control outcomes. So I'm aware that Martijn is launching that analysis again now for the outcomes of interest.
Mark has thankfully reminded me that I slipped up in my description of the 2009-2010 season, which of course we remember was the H1N1 pandemic. So apologies for misspeaking about that. But certainly what we're hoping for is the last time we saw a bad virus circling around, we want to understand, is there anything we can learn from that process and carry that in forward into this 2019-20 season. All right, another question we have. For the predictions, are we developing a model across sites or are we validating one that has already been developed within one or more of the sites? I'll comment on this as I best understand where the prediction team's head at, and if somebody wants to correct me, then if I misspeak. So my understanding, and Peter, maybe if you can jump in if I get it wrong, but my understanding is that our goal here is to initially do internal validation across a series of databases that are available to run the internal validation. What we hope to do is look across those different models to understand whether or not they generally seem to be consistent, both in terms of their performance, but also in terms of the characteristics that they seem to be selecting. On the basis of those, we'll make some sort of a model selection from what we've observed, and then we will package that model up for external validation, meaning we'll ask other sites to run that model. In parallel, as that's going on, we are going to seek to try to understand, can we actually create some sort of simplified model based on the insights that we've gained, and try to develop that as well. I know that what we're actually looking to do for the patient level prediction work is going to be very much a journey. If we think of internal validation as basically providing us the maximum predictive accuracy that we likely can achieve, the question is how close could we get to that if we develop a simple model, and how transportable is both the overall maximal model as well as some sort of simple model that we can comply out everywhere. So I expect that the patient level prediction group is going to be working through multiple models as we go through this. What we'll expect to see tomorrow, hopefully, is results from the internal validation and packaged up so that we can get external validation results on those internal models. But then I expect we're going to be having a continued collaboration to see if we can create something that's more readily accessible with a simple model. Peter, is there anything you want to add to that?
No, you summarized it very well. One nice option would be to validate those models on the Korean data. So we're still exploring that, of course.
All right. There's a question about, so can we provide the hyperlinks to the studies that are ready to go? It's not evident from the team views what is ready to run. So for those of you who are data partners that are looking to run something against your data, please be paying close attention to the network execution channel that Kristen and Talita are leading. They're trying to make sure that we're keeping control of the version control and making sure that everybody has the appropriate links to the latest packages. To be clear, the one that we're, I think, promoting right now to get out is Ed's the characterization package, which is out on Ed's GitHub repo. So this is something that people can download and run. Though I will ask that you connect with the network execution channel, and particularly Kristen, to make sure that that you're coordinating your priority activities. The prediction work that I showed you, that is still in the development environment, though I expect that Jenna, myself, and other members of the team are going to get that packaged up here in the next couple hours to make sure that that's available and ready to be run, certainly by our colleagues in Korea as they are arising, but hopefully we'll also certainly going to be able to kick it off on a couple of American sites before those of us on this side of the pond go to bed. So look for the next network execution channel to find the appropriate links and the directions of which packages to install when. Any other questions from the community? Well, I'm not seeing any other questions come in, even though I do see a great deal of you online. I just want to take a moment to thank all of you for your hard work. I recognize fully that this is a Saturday for many of you, a Sunday morning for some of you, and that you're taking time away from your family and friends and your personal time to do this. I, for one, can say I've never worked so hard for a continuous 18-hour session as I did today, and yet I don't think I've ever been more energized and focused. Even though it's in the evening now, I can't imagine doing anything other than continuing to plow forward on this, because now what we're seeing between Danny's results with the estimation results showing us that we have real promise to make a difference in our understanding of hydroxychloroquine, to see Ed's work and seeing that we have a characterization package ready to summarize the real world experience of patients, and to see the work that's coming out of prediction to create real models that are directly informing the clinical problems that are being faced by healthcare professionals and patients around the world. To me, this is what it's all about. So I want to thank you all for your dedicated attention and focus on this. And thank you for your continuing to push through for the rest of this Study-A-Thon. And thank you in advance for continuing on this journey with all of us so that we can generate this evidence and try to do what we can to make this evidence inform better healthcare decisions and better care. And with that, we'll let you guys. Oh, there's one more question. Late addition here. Question: can we perform temporal characterization of the symptoms of the cases? Yeah. So one of the things that I failed to show, but actually for the prediction work, we actually are going to be creating predictions across multiple time windows. So basically, each of the segments of the flu seasons. Each of the segments of the viral seasons are going to be evaluated. So we'll have the H1N1 season, the 2014 to 2019 kind of baseline flu seasons, and then the current season. The current focus there is to look at changes over time as it relates to the season level. There's been discussion, and I know on the characterization side, about whether or not we can also start to drill in even further in our characterization to look for changes in the symptoms of these diseases over time, even within a given season. So, for example, for those patients presenting with flu, cough, myalgia, malaise, are the composition of those actually changing month by month? And I think there's going to be a real opportunity for us to be able to stratify our analysis by kind of monthly periods of time. I don't think we have the data yet to do that, or we definitely don't have the data yet to do that right now, but it seems like a very laudable characterization study that we should absolutely be building upon what we've developed here so that we can actually understand the trajectory of these symptoms across seasons and within seasons to understand if we can gain any insights that may help us follow this disease further. Danny, any closing thoughts for you?
No, I'm delighted to see people working so hard for such an important problem, and I'm just looking forward to seeing tomorrow when I wake up what you guys have got from the new analysis that are now running. Thank you, Marta and Jamie and Christine, who are working very hard to get some findings for us tomorrow.
Yeah, thank you, everybody. It's been an amazing journey thus far. I'm so impressed and humbled by the progress and the effort that you're putting in this, and I'm very excited to see what we actually can produce tomorrow as we prepare all of these packages and start to deliver out on our results. So good luck for the next 8 hours, continuing this work. I look forward to seeing you at 3 a.m. my time and eager to see what you have to show me. Thank you all very much. For those of you in Europe, get some sleep. For those of you in the US, get to work. And for those of you in Asia, good morning. Look forward to collaborating for the next few hours. See you all soon.
See you tomorrow.